Thank you. So I'm back again. I'm going to talk about something else. But I'm going to describe the study that I did, and it's in keeping with what I've spoken of before, using the computer and collecting data and coming to conclusions based on our data collection. Now, I'm going to talk about venous thromboembolism, and basically, as we talked about prophylaxis, prevention of SSIs, surgical site infections, for example. We seek to prevent other things from happening, like VTEs, venous thromboembolic episodes. We prevent it with, there's two different ways of preventing it. One is mechanical, where we use sequential compression devices. We wrap the legs with these devices, and it compresses the leg. For the venous pooling, it helps. We can also use pharmacological means by using thrombolytic agents and taking that medication for that purpose. So I did a study looking at all of our cesareans, and we did this where I will tell you about the study that I did for every gynecologic procedure, but then we also looked at cesareans, specifically looking at cesareans when no chemoprophylaxis was given, and cesareans when VTE chemoprophylaxis was given, finding out if there were hemorrhagic complications or VTEs in either of these settings. And to backtrack a little bit to explain, this was a enterprise. It used an enterprise data warehouse. In other words, of all the electronic claims for the multi-hospital system. And what I did is looked at all of the surgical procedures performed for 4 years throughout all of the hospitals, and came up with 330,000 surgical cases. 337,000 to be exact. I counted every one. So the fact is that when looking at the electronic data submissions, we have to look at the coding that was used. We use the ICD codes, and in the United States, we have now started collecting it using the International Classification of Diseases version 10. We've been using version 9 for many years, so we've kept up with Europe. And so it's ICD. So we just caught up to Saudi Arabia and everywhere else in the world. I'm of course ready for ICD 11, but that's another story. So
this one's too complicated.
Well, 11's. Well, but there is, okay, let me defend ICD version 10. By the complexity of the data that we're collecting, we can come up with better conclusions because the details of the outcome is something that we need in order to determine. Now, yes, it's not always important if it's right-sided or left-sided. I understand that. But it is important when you talk about congestive heart failure. It matters. We all think of congestive heart failure as left-sided, but sometimes it could be right-sided, giving pulmonary complications. So the specificity of the ICD-10 gives us better information, and better information is better. So, okay. Now, having defended ICD-10, now, this is just showing you all of the data for the, this is the 337,000 cases, and I cared about the gynecologic cases, which there were 17,000 in this big pool. The 17,000 is what I looked at gynecologic, how many VTEs we had, 74 venous thromboembolic episodes, But I cared more about what was happening with regard to the gynecologic hemorrhagic complications that occurred, because as one can see here, it occurred more commonly when we gave chemical thromboprophylaxis than when we didn't. I mean, that was statistically significant comparison, and so we have to be careful about when we elect to use chemothromboprophylaxis. Now, I specifically looked at cesarean deliveries, and we had 24,000 cesarean deliveries in this data pool. Now, you might notice that it was. Let me go back here. There's a pointer somewhere here, but I'll use my finger.
Here, it's right here, Elliot. Right here.
Oh.
Yeah.
Okay, thank you. Well, now I'll use the fancy electronics here, and oh, there we go. Okay, so my whole, trying to get the pointer, I was merely showing you, and it's not coincidental because in the literature we have found that the incidence of VTE after cesarean occurs about 1 in 1,000 times. This is kind of in the textbooks. Well, so in reality, in the cases that I described here, what do you know? Of the 24,000 cesareans, there were 23 VTEs. So this is consistent with what we've already known. But I alert you to the fact that we found cesarean hemorrhagic complications in, what do you know, an equal number of cases. It just so happens that it was exactly the same incidence. So we should be careful when we provide some prophylactic measure to prevent this from happening, when we can also cause this to happen. The whole point of it is that we have to select when to use these pharmacologic therapies, and that is what we refer to as risk stratification. In other words, deciding those that are particularly high risk, well, then you should use the most effective tool, and that would be pharmacologic medications. But for everybody else that may not be at such a high risk of that happening, perhaps we can use the more, the less complicated associated thing of using venous, sequential compression devices, or SCDs. See, it's a lot easier to say SCD than what it stands for. So we look to see, and there are various tools that have been used to decide who is at particularly high risk. Now, this is using the Caprini scale, and I don't agree to using it because there are things that I might say, well, where is the data? Because if something occurs 1 in 1,000 times, you need a denominator that is much larger to identify those risks. And I'm saying that those studies are not really being done as well as what I tried to do. There is great controversy about whether someone taking oral contraceptives is at risk, and that's a whole nother talk, but I won't get into that. But the point is that there are many things on this scale that may not be as evidence-based as we would like. There is another scale that is used, that we are using actually at Advocate, where it's much more simplified, because we identify those things that really are risks, and we all know about malignancy. Someone that has a past history of VTE, well, they are tenfold greater risk of it happening again. So that's where thrombophilias, that's something we screen for obstetrically. So when we identify, that's not a very common thing, but when we identify it, okay, that is a real risk factor that we should do whatever it takes. Again, ongoing hormonal therapy has been somewhat exploded in the literature or in the popular literature, but is not as scientifically proven as some may think. So the whole point of recognizing the risk factors, and we all know about obesity or elevated BMI, older age, a 40-year-old may be at greater risk than a 20-year-old. I mean, these are a past history of VTE, thrombophilia, malignancy. These are all things that we have to consider as particular risk factors for VTE. Well, the point here again, I'm mentioning that we use a big data pool when speaking of a low incidence phenomenon, such as VTE. 1 in 1,000 times is not real common, so you need to collect a lot of data in order to come to any conclusion. We really recognize that the incidence varies according to those risks. I've mentioned what they are. The incidence certainly can be minimized by selection of the prophylaxis that we'll use. The compression devices, the SCDs, has been shown to be effective, and they virtually have no downside, and except for some short-term discomfort, which is quite minimal. And I can say that myself, because I actually had an accident, so I was in intensive care unit. That's not obstetrically, but the point is that I was hit by a car, and so I was in the intensive care unit, and so I know what it is to have my legs wrapped. Big deal. I mean, it's really, it shouldn't be exaggerated, in my opinion. I can say, but I can get up here and say that because I'm, a victim. Okay. Okay, so I was in the intensive care unit for a month. I was in a month in inpatient rehab. I was in the hospital for 2 months. I never have a patient in the hospital that long, but that's another story. So the point here is that that we know that we should recognize the potential hemorrhagic complications that we can cause, and we should be careful and selective in terms of who should get that. Basically, we recognize the value of using prophylaxis, and I will, of course, argue for the collection of our electronic data to come to these conclusions. We have to be careful what we call a VTE, because basically if somebody gets a chest CT and they show some subsegmental infarcted areas, but the patient has no dyspnea, no tachycardia, she is perfectly fine. You did it for some other reason, and we're going to now call that a VTE, but we would never have called it a VTE before, so we have to be careful about the use of our language. And that's the story.
That's a story.
Thanks. Wait, say that again? I'm sorry. Oh, yes. Go ahead, get me started. No, I believe that the data, the Royal College, and in the United States, we have the American College of Chest Medicine, ACCM, or ACCP, I'm sorry. The American College of Chest Physicians coming out with recommendations along with the Royal College as well, but I believe that, again, the enormity of the data that has to be collected to come to the conclusions, I don't believe was adequately done. So the recommendations, and this is what I'm getting to here, I'll move away from cesarean and say for gynecologic surgery that we perform, it is recommended to give chemical thromboprophylaxis in cases where the American College of Obstetrics and Gynecology, ACOG, says you should reserve for the highest level of risk whereas that is not what is stated by the Royal College or by the ACCP. So we all, physicians, have to be careful, well, who are you going to follow, whose rules? And so I know we are talking about just that, and this is a perfect place to talk about the Royal College and other organizations that give us recommendations, because we need to have something to follow. But you see, in this area of VTE, it could be confusing, because I believe we may be missing the point of the causation of hemorrhage that is possible, and we should be selective, therefore. So I'm not sure about what the Royal College says about cesarean prophylaxis, and I'll look it up, but I won't follow it anyway.
The problem is the Royal College changed their opinion from 3 days post-cesarean protection by injection of heparin
Yes.
for 3 days for women post-cesarean in the late 2014 to 10 days.
10 days.
And the American College changed to the same from 3 days to 10 days in the early 2015, the same.
But except for who it's recommended for. So in other words, the American College, if a woman has thrombophilia, sure. If you want to go 10.
They put it for all cesarean patients.
Okay.
No, but they divide it for low risk, medium
Yes,
risk, and high risk.
highest, yeah, exactly.
Right, and I understand that. But again, we have to be careful, because if you go to 10 days, please look and observe to see how much hemorrhage will occur. But you have to look at 10,000 or 100,000. That's not being done. So we should be careful before giving recommendations without actually looking at the data.
They divided low risk, medium risk, and high risk. For low risk, there is no need for
Right.
Well, but
Right.
do we know that if we haven't looked at large numbers?
Well, but see, now what's interesting, that our language, we have to be careful, because the American College, they have 4 categories. They have low, moderate, high, and highest. So there's a 4th category, and they conclude that only give that medication to the highest. Well, now, of course, I want to know, well, who's highest and who's high, and it gets kind of confusing. And it's confusing for me, and I actually study this, so, to everyone, good luck.